Hello, and welcome to the first in a two-part series on risk adjustment. This session will introduce the concept of risk adjustment and go over the most common models and uses of risk adjustment. I'm here with Detty, and I'll be leading this discussion. So what is risk adjustment? Risk adjustment is a statistical process that considers the underlying health status and health spending of the enrollees of a given insurance plan. That is, it is a method that is used to appropriately compensate both insurance plans and healthcare practices and providers for the costs associated with the level of illness in their patient and member populations. It's really aimed to level the playing field, so to speak, for plans and providers who provide services to sicker patient populations. So reimbursement for covering care of sicker populations is adjusted positively, while reimbursement for covering the care for healthier populations is adjusted negatively. Most risk adjustment models contain at least two components. So a demographic risk is calculated based upon a patient's age, sex, race, and ethnicity. And then a condition score that is based upon a set of diagnosis codes primarily sourced from claim submissions. Some risk adjustment models may also include pharmaceutical drug codes as part of that overall health status score. And some models may also allow for supplemental code submissions outside the regular claim process. But primarily, the source for the medical condition information comes from those claim diagnoses and claim submissions. There are several different models of risk adjustment that are in existence. The Centers for Medicare and Medicaid Services, or the CMS-HCC model, is likely the most widely discussed among HIM professionals. HCCs, or hierarchical condition categories, are a subset of diagnosis codes that have weights associated with them. Those weights are additive and combine with a patient's demographic score to create an individual's risk adjustment factor, or RAF. A RAF is then used to adjust the payments to the healthcare organizations, providers, and practices. There are currently 19 CMS HCC categories, representing 86 HCC codes, which are then comprised of almost 10,000 individual ICD-10 diagnosis codes. The CMS HCC codes were determined using the chronic conditions that are associated mainly with a Medicare population. So that brings us to the next model, which is the HHS, or Health and Human Services HCC model. It's calculated very similar to the CMS HCC model. However, the HCC categories and codes have been modified to apply to a younger, non-Medicare population. And it's most widely used in the health insurance exchange plans. Examples of those additional HCC codes include infant, children, and obstetrical conditions that aren't prevalent in a Medicare population. HHS HCCs are comprised then of 254 individual codes, and it includes pharmaceutical NDCs and the underlying code sets that make up each one of those. Pharmaceuticals are not included in the CMS HCC models. For the Chronic Illness and Disability Payment System, or CDPS risk adjustment model, it's mainly used across the U.S. to risk adjust populations on Medicaid. The CDPS model categorizes all the major body systems and type of chronic disease, and then weights diagnoses based on clinical severity and expected future costs. It's similar to an HHS HCC model in that it includes weights for infant, pediatric, and obstetric conditions that are more common among a Medicaid population. And the CDPS plus RX methodology is the same medical methodology as CDPS alone. It simply adds pharmaceutical NDC codes and weights based upon the pharmaceutical category. Finally, commercial health plans use a variety of risk adjustment models to predict risk associated with their patient population. Johns Hopkins Adjusted Clinical Group, or ACG, measures the health status of a population by grouping diagnoses into clinical logical groups. Milliman Advanced Risk Adjusters, or MARA, uses an algorithm that considers disease progression over time. And while HCC and CDPS models are very population specific, many of these other risk adjustment models used within the commercial population, such as ACG and MARA, can be population agnostic in that they can apply to all populations together and allow a healthcare organization to risk adjust an entire patient population using a similar algorithm. Different risk adjustment models use different time frames to gather diagnostic data to determine health risk. So the CMS HCC model, which are the green boxes above, uses a base year measurement period to then predict the risk to the next year's measurement period. But then we'll adjust the payments for the year after that, and it's all based upon a calendar year. You also see next the HHS HCC model in yellow uses the same year diagnoses to predict that year's risk, and then payments again in the year to follow. So it's a little bit of a condensed time frame compared to the CMS model. The CDPS and CDPS RX models are in pink and purple, and they work a little differently. So you'll see in these that they typically use a 12-month look back for baseline and measurement, but then they actually only risk adjust payments at a 6-month interval instead of a full year interval. So CDPS risk for patients may be based upon a risk for a period up to 18 months to 2 years ago, where you'll see CMS models is usually 2 years for the gathering of diagnostic data, and HHS is usually a 1-year lag for gathering of diagnostic data. This often means that initiatives to improve risk documentation are often not realized for at least a year, sometimes 2 into the future. This makes the measurement of initiatives around risk adjustment challenging for most healthcare organizations, as many rely on measuring internal process measures and project future risk impact due to this delay in realization. So why does risk adjustment matter? We are going to use a capitation payment model where a healthcare practice or system is paid a capitated dollar amount per patient per month to cover their full cost of care. As an example, to demonstrate the effect risk adjustment can have on an organization's revenue. This is a simplified model and likely one of the most straightforward risk adjustment payment models out there to understand. But do keep in mind that most value-based or pay-for-performance models also risk adjust their payments based on the health status of the population. If the health status of a population then is not accurately coded, any generated shared savings, bonus dollars, and any kind of pay for performance can be adjusted and significantly impact the healthcare organization's revenue. So let's say, for example, that we have 3 patients who are female, 72 years of age, and under a capitated payment structure. Patient A has not had any conditions coded in the measurement period, so her risk is solely based upon her demographic score of 0.346. Patient B, let's say, has had a single visit with a diagnosis code of E11.9, which is type 2 diabetes without complication. So the HCC weight for diabetes without complication, or HCC 19, of 0.105 is added to that demographic weight of 3.46. And you can see here becomes an individual RAF score of 0.451. Now let's say patient C has had several visits, the first of which has that same E11.9 diagnosis code, but then several more recent visits with a diagnosis code of E11.41, which is type 2 diabetes with diabetic mononeuropathy. So the HCC weight for diabetes with a chronic complication, or HCC 18, is 0.302. And so when added to patient C's demographic risk score, you get a total risk adjustment factor of 0.648. So this is meant to estimate the disease burden of this 3-person population here. So in a capitated model, the risk adjustment factor is used to adjust the monthly payment for each member across the entire population. For example, this may be across all Medicare patients on this particular Medicare Advantage plan. So to do this, an average RAF score for the entire population is calculated. So we're just going to say, for calculation purposes, that average RAF score is 0.505. So that means your average person in this plan has a 0.505 RAF. So then to calculate what proportion of payments for each of these three patients would receive, we normalize their RAF score to that average. That is, we're going to divide their individual RAF score by the average RAF and get the proportion of their risk adjustment compared to the mean of the entire population. So this is then used to calculate the monthly capitation rates for the patient. So you'll see for patient A, if we take the 0.346, divide by 0.505, we get a normalized RAF score of 0.685. So then if the capitation rate for the whole plan is to average $500 per member per month, we can use the normalized risk score, multiply it by that $500, and get the calculated payment for the care of each of these patients. This then gives you the monetary difference of the risk adjustment per patient. So if you look at patient A with no HCC condition code, their monthly per patient per month payment to cover their cost of care is going to end up being $342.50. If we compare that to a patient who's been coded very specifically with diabetes with mononeuropathy, or our patient C here, their monthly per member per month capitated payment is going to be $641 to cover their cost of care. So patient C has almost double the capitation payment of patient A. So while that difference, which is roughly around $299 a month, may not sound like much for a large healthcare practice, remember that that's just the difference between no HCC condition being coded on a claim and a specified HCC code submitted on a claim for just one patient for just 1 month. So the implications for this for, say, 1,000 patients over 12 months or 10,000 patients can really add up. And in my previous work with provider-led accountable care organizations and clinically integrated networks, it's not uncommon for data analysis to show that these estimated dollars that are being sort of left on the table for patients who we suspect may not be fully coded to the specificity of their condition on their claim, to be a much larger revenue gain than any other performance or quality improvement initiative across the organization. Sometimes it's even more potential revenue than all of the other quality improvement initiatives put together. So coding improvements for risk adjustment are often investments that take years to reap the financial benefits and can be challenging to estimate ROI, but they can also be very impactful in a health organization's revenue. So data analytics can use diagnosis coding trend analyses to help identify and overcome some of the coding challenges in risk adjustment. They can measure process outcomes during intervention, even when ROIs may not be realized for a few years down the line. But most importantly, if accurate and specific coding is robust and consistent on the front line, it often reduces the need for more resource-intensive improvement projects and initiatives down the line. So to summarize, risk adjustment is a statistical method for estimating the health status and future costs of a patient population. It is a key component of revenue cycle management, as most insurers and payment models use some form of risk adjustment as a means to adjust payments based upon the perceived healthcare risk of a patient population. The backbone of any risk adjustment model is diagnostic coding, and it's coding across all areas of a healthcare continuum. So HIM professionals are keenly poised in positions across that continuum to ensure that payers have the most accurate diagnosis data on which to risk adjust those provider and organizational payments. There are many potential careers for HIM professionals in risk adjustment. Careers in coding or coding analytics all involve risk adjustment or touch risk adjustment in some way. These careers may be listed under a variety of job titles, and I've listed some examples here, but generally any medical, dental, vision, coding, or billing position title, or any coding or billing analyst, auditor, or quality assurance title fits into these first two categories. But there are also careers that are very specific to risk adjustment for HIM professionals. And some examples are listed in the third box all the way to the right here. Some will have risk adjustment in the title, such as a risk adjustment coder or risk adjustment coding auditor. However, some titles may actually be specific to the risk adjustment model being used, such as an HCC coding specialist or an HCC risk auditor. Also, just to note that the specialization increases as you move horizontally from left to right here. So experience as a coder is generally a prerequisite for coding analysis positions. And experience in either coding or coding analysis is often preferred in positions specific to risk adjustment. If you want to learn more, OHIMA has developed a revenue cycle hub for you to easily access informational videos, including this video today, as well as articles, careers, certifications, and education related to the revenue cycle. If you are interested in exploring careers in the revenue cycle or simply like to learn more, you can scan the QR code on the screen or visit ohima.org/revenue cycle. All of OHIMA's resource information videos will be available under that resources tab at the bottom in green. Stay tuned for the second part of this series. It's going to take a deeper look into the impact of coding on risk adjustment. And thank you for joining me today, and I hope you found this presentation helpful.